Now, this is a common problem. We know that cardiogenic shock accounts for about 10% of cases of AMI and has a significant mortality associated with it. So data varies from between 30 and 50% 30-day mortality associated with presentation of shock. So when you have such a case presenting to your lab, it's a high-risk case, it's a complex case. So how do we approach it? Well, I think the first thing that I tend to think about is what access site to use. So this is the largest data available around access site utilization in cardiogenic shock in the setting of cases that you wish to perform PCI. This was published in my group. This is around 7,000 cases. And you can see that whilst there's no randomized controlled trials, going radially is associated with better outcomes. Certainly when you adjust for differences in baseline covariates, there's a significant reduction in 30-day mortality associated with the radial approach. Now, you may say that there's elements of selection bias here. Less sick patients are more likely to get radial approach, and I'm sure that part of the benefits relate to this. Nevertheless, I do believe that there is a mortality benefit around access site use in cardiogenic shock. We've seen that with STEMI, and we also know that the magnitude of benefits associated with adoption of the radial approach relates to baseline bleeding risk. The greater the bleeding risk, the greater the benefit, as seen here from some of our earlier work from over a decade ago. And you also know that cardiogenic shock is a high bleeding risk case. In most of the bleeding risk scores, we know that cardiogenic shock is a covariate. So moving on from access site practice, how about antithrombotic therapy, and why is this important? Well, cardiogenic shock is one of the strongest predictors of stent thrombosis. So in many studies, it's independently associated with a 12-fold increase in risk. And we don't have good randomized or any randomized controlled trial data for that matter around antiplatelet utilization, but the work from Adnan Kastratian group from the ISAR shock registry would suggest that perhaps using a more potent antiplatelet agent such as prasugrel is associated with better outcomes. Remember, this is not randomized controlled trial data, this is observational data, but certainly when this group looked at platelet inhibition in shock patients, it was far greater in the prasugrel group compared to the clopidogrel group, so certainly would make biological sense. And this is further data around if you do decide to use prasugrel, do you give whole tablets or do you crush the medication? This was the CRUSH trial, randomizing patients to either crushed prasugrel or whole tablet prasugrel. And the important thing to notice here is that when you look at platelet reactivity, certainly within the very first 30 minutes or so, you can see that crushed prasugrel is associated with much stronger and much more effective platelet inhibition than whole prasugrel tablets. And actually, it takes around 6 hours for the degree of platelet inhibition to be associated to a similar extent between crushed and non-crushed prasugrel. So when managing patients with shock, crush the tablets, you'll get much more rapid platelet inhibition in this group. The other thing that one can do is use Cangrelor. I don't know what the situation is in India. In the UK, we don't have access to Cangrelor, and certainly we don't use it in my centre, but certainly this is data from the CANTIC study in patients with STEMI undergoing primary PCI, and you can see that utilization of Cangrelor was associated with much faster platelet inhibition. So certainly in shock case patients, utilization of Cangrelor would inhibit your platelets much more effectively, but you always have to balance that against the risk of bleeding complications. So in terms of, what do you do to your patients? I mean, John has presented this study. I'm going to present some of the data around this. Patients with cardiogenic shock often have multivessel PCI. If you look at the registry data, between 30 and 50% of patients have multivessel PCI, and we know that those patients with multivessel disease have worse outcomes. We know that multivessel disease is an independent predictor of poor prognosis. And And really, the culprit shock trial set about trying to find out whether multi-vessel PCI in this context is associated with better outcomes. Certainly, much of the observational data was conflicting. There were some studies that showed better outcomes, some studies showed worse outcomes, and that's why we do randomized control trials. So this was a randomized control trial of over 1,000 patients, randomized, both STEMI and NSTEMI, to either culprit PCI or multi-vessel PCI. There was a load of inclusion criteria that you can see here. Clearly, multi-vessel coronary artery disease was a key inclusion criteria, as was the presence of cardiogenic shock. And there were multiple exclusion criteria, one of which being futility. There's no point entering patients in whom PCI would be futile. And again, patients where there was a mechanical cause of cardiogenic shock were also excluded. And they had, half a dozen endpoints. The main endpoints was all-cause death, severe renal failure requiring renal replacement therapy, and secondary endpoints were individual components of the primary endpoint and several other endpoints that have been published. And this is the primary endpoint. So all-cause mortality or renal replacement therapy was associated with a 20% reduction in the relative risks associated with culprit lesion-only PCI. That is to say, multi-vessel PCI immediately is associated with harm. All-cause mortality, again, a 15% reduction in all-cause mortality associated with culprit lesion PCI, and a trend towards more renal replacement therapy required in multi-vessel PCI. And I think this is biologically plausible. Why? Because the volume of contrast in this trial was significantly greater in the multi-vessel PCI arm compared to the culprit lesion PCI arm. And when you look at glomerular filtration rate, you can see that certainly in the multi-vessel PCI arm, there's a far greater deterioration in renal function than there is in culprit lesion-only arm. When looking at the subgroup analysis, the benefit is consistent. What do we do about staging? I personally staged the cases. There isn't good randomized controlled trial data around staged PCI in this group, but we know that in patients with shock, assuming they survive past 30 days, then incomplete revascularization portends to worse outcomes. Again, this is observational data, whether it's the incomplete revascularization that's driving these bad outcomes or whether it's the clinical factors that portend to the decision not to completely revasc the patients that lead to the worse outcomes is unclear, but my practice is for aiming for complete revasc if the patient survives the event, and I generally stage it as an outpatient. Now, this is really quite important, and I guess, in terms of thinking about procedurally how we manage these patients, when looking at stent thrombosis in these patients, we see a very high rate of stent thrombosis in patients with cardiogenic shock. And we see that cardiogenic shock is one of the strong predictors of stent thrombosis. This is single centre data from the UK, from Sheffield. And you can see that when looking at the risk of definite and probable stent thrombosis or definite stent thrombosis, cardiogenic shock is independently associated with an 8-fold increase in risk of definite and probable stent thrombosis and a 5-fold increase in definite stent thrombosis. Most of this excess risk appears to be early in the acute and subacute stage with a 12-fold increase in risk. So stent thrombosis is a big problem of these patients. So again, potent antiplatelet therapy, clutch tablets, Cangrelor. We don't have data, interestingly, around shock and intravascular imaging. That's something that my group is looking at with the British Society of Interventional Cardiology dataset. It's something that we hope to report in the next few months, but as of this time, we don't have any good observational or randomized control trial data around imaging use and cardiogenic shock, but certainly from the ACS perspective, there is lots of data. This is just one of many data showing that imaging use in patients undergoing PCI for ACS is associated with reductions in cardiac death, target vessel MI, stent thrombosis. So in my view, imaging should be mandatory in these patients, and certainly when I treat cardiogenic shock patients, I always undertake intracoronary imaging. So I think in conclusion, PCI in assessing of cardiogenic shock is high risk. It's the strongest predictor of both bleeding and ischemic events. I think where feasible, we should be using radial access. There's very good randomized controlled trial data, certainly in the acute coronary syndrome setting. There's no RCT data in shock, but observational data published by my group and many others have shown benefits of using the radial approach. We know that cardiogenic shock is one of the strongest predictors of stent thrombosis, so use potent antiplatelet therapies and crush them. At the time of the procedure, only culprit PCI, but I would personally stage them if the patient survives to discharge. Use imaging and LV support is probably another talk, so I'm not going to talk about that. Thank you.